I'd like to introduce my friend Lori Lubach. She is from Covenant Hospital and she works in the respiratory area, in their rehab area. So she has lots and lots of experience with the trach and trachcare, and that's what she's going to be talking with you this morning about, is trachs, the different kinds. She's going to be talking about the care of the trach and some other tips on how to handle trach. So go for it.
All right. Can you all see my board from back there, or can I pull it up?
You can pull it up. Oh, we don't want to lose this again. We don't want on camera. Okay. Good, Michael.
A few of the trachs that we get, the common are Shileys and a few Bavonas. Is anybody familiar or seen the two different trachs before? Okay. This one here is Bavona, and I'll pass these around too. This is all one piece, and you can identify these trachs by the markings on the flange. Okay. The other common one is a Shiley. Again, you can identify everything about your trachs on the flange. Now in your packet there, I have given you a printout on another trach that I had never seen before that come into our facility. And I do use a computer a lot, so if I don't know what it is, I'll just type it into the computer and learn more about that trach. The one that I gave you a printout on is another Shiley that they use on patients that have a bigger neck, and that maybe their chin will occlude the opening of a regular trach. So that other one is one that I experienced with an obese patient. And I learned about that on the computer, and that one is a disposable cannula, which I didn't know. So I printed that one off for you too, for your information. Now these Shiley trachs come in different sizes. And again, you will look at your flange. Primarily 4, 6, 8s. The Bavonas, again, different sizes too. There is also a Bavona here for obese patients that also protrudes so that the chin does not occlude their airway. That's, I also have a picture here of that. And they are one piece, and they remind me of an endo tube, basically. I mean, they're long, that long, they protrude out the neck that long. Now, there's a difference in the trachs. There's fenestrated and non-fenestrated. The fenestrated has the holes in it. The non-fenestrated does not. There are ones with cuffs and ones with no cuff. As for the Bavonas, they are all cuffed. Some of them, their cuffs, though, you do in still normal saline. The trachs, they either have a permanent intercannula or a disposable intercannula. And the way that you can tell the difference is with the disposable, they have a pinch clip. And with the, now I have to use my guide here, permanent intercannula, they have a dot-to-dot system where you line up your dots and twist. The disposable, of course, when you're doing your trach care, you just take it out and throw it away. This one you have to do the sterile cleaning on. Okay. So remember, if it has two blue dots, it's a permanent intercannula. Clips, you throw it away. Now, at our facility, every person that comes in with a trach has to have a backup trach at bedside. So you want to get the equivalent size. For instance, our facility stocks Shileys. So if a patient comes in with a Bavona number 8, and in your packets, you've got a comparable size guide. A comparable trach for that, for my backup, is a Shiley number 6. And what you need to look for is, and I don't know what you're going to use here, you want to make sure that your outer diameter of that trach, backup trach, is not bigger than the trach that they currently have in. For instance, if you have a Bavona trach with a outer diameter of 11, you're going to look for the Shiley trach with the outer diameter less than 11. I think the number 6 is 10.2, maybe. And another thing from experience, a lot of patients that transfer into our facility there, they come with their some trachcare supplies, maybe their peroxide, their suction kits, etc., and maybe a backup trach. But from experience, they come in boxes. You need to open that box up and make sure there's a trach in there. Don't just assume. Because in event of emergency, if that patient's trach come out, you want to make sure that it's in that box. And I'm just telling you that from experience. There was a box left at bedside as a backup trach, and there was nothing in it except the little brochure. A lot of times, I don't know if you'll see the operator or the guide hanging next to the bed. That guide is in the box also. It is a assistance device for the placement of that trach. In the boxes of the trachs too, you can also have their plugs. Like at the facility I work at, the trachs that come in, our goal is to decannulate the patients. So everything that you need to wean that patient from that trach is in that box also. For instance, the disposable cannula patients, they have a clip plug. For the ones that have the permanent, you take the inner cannula out and this plugs. If they have a cuff, remember, before we can ever plug them, we have to deflate that. Now, our facility, if a patient comes in with a Bavona trach, they always have the cuffs. And it's deflated. We are going to try them with the speaking valve first. We're going to make sure that there's enough air that we can create a sound. But it's not, a patient can wear this valve, but still not be able to be capped because there's still not enough air going up over the vocal cords, or maybe they can't catch your breath. For instance, with the Bavona, it's very rare that we'll try and cap a patient with a Bavona because they have difficulty breathing or even getting enough air around that cuff. So we will downsize that trach. And the trachs that we use are the 6 CFS. That's an uncuffed, unfenestrated trach that allows for adequate movement of it so they can breathe once we cap them. Metal trachs, we very, very rarely have them. We just, in fact, had a patient who's a U of M patient that he was on a permanent trach at home. That's the only time we see them. For them, for this patient in particular, he changed his trach by himself. All we did was clean it up for him because he was used to having it. Now, it's protocol, you have to have the ambu bag and you have to be able to ventilate anybody with a trach at home. The only problems with these metal trachs are you do not have that 15mm flange here for you to ventilate a patient. the patient that did come in did have a little lip that I was able to find a barrel adapter and an elbow and connect to in case I had to ventilate them. But otherwise, you'd have to bag mask them if you weren't able to ventilate through the trach. These are all uncuffed too. They're very rigid, so they are very, very rarely used. But like I said, it may be one that comes into the hospital. Any questions so far? Now, trach care. We do sterile trach care. We have a, on your sheet that I gave you, there's just some suggestions on supplies to gather. Every trach care kit is different. We've had different vendors. We've had different supplies come in these kits. They're shaped different, so I don't know what you're going to use. Now mine comes with 2 slots, and I use peroxide and normal saline in both. Right now we're kind of in question about what we're going to use. They said we no longer have to use peroxide with trach care cleaning, but we prefer to, so it hasn't been changed on the sheets. Normal saline. The first thing I do in the morning is I go and grab normal saline because I'm going to do my trach care. It must be dated, timed, and initialed. It's only good for 24 hours. Peroxide, again, dated, initial, time, is good for 30 days. Before I do my trach care, because I do the breathing treatments, the suctioning, which it allows us to do on your patients, I'm getting set up. And of course, my patient's on humidified oxygen because any open trach has to have humidified oxygen. We use cold humidity there, not heated. The only time that a trach patient does not have to have humidified oxygen on him is if he is capped. Because again, we're redirecting the airflow up through the nose, which is the humidifier. Okay? Even with the speaking valve, if you have a patient that comes in with a speaking valve, that needs to have humidified O2. The only time that we do not have humidified O2 or put this on them is, let's say that they have to go down to X-ray, and at that point we'll just put them on a venti mask, because every trach should be covered. Even if this patient's oxygen level is great on room air, you don't want to send somebody out into the hallway with an uncovered trach in case they cough, and you don't ever want that. So I've already given my guy his breathing treatment and suctioned him, explained what I'm doing. I've gathered my supplies. My supply in the way that I do things may differ from the way that you want to do. I like to use the cotton tip applicators to clean. Some people like to use the gauze, which is fine. But once you get that gauze wet, you know, it just goes into like a little ball. Now you can use the 4 corners of the gauze, but once it's saturated, like I said, in the little ball, you can't find it. So what I do is I take the sterile tip applicators, and I'll get 8 of them, and you're going to take peroxide and move it out and away on like the 4 corners of the flange, the top and the bottom. But remember that every time you use the saline or the peroxide, you have to wipe it off with saline. So we've used peroxide, saline, rinsed it off on all 4 sides. And you should have the gauze in there to dry. So if you have the 4-cornered gauze in there, you're gonna use a corner and dry, twist the gauze and dry, twist the gauze and dry. Now, like I said, all the trachcare kits are different. So when I set up, right now we have one with 2 containers. With his trach, you have the inner cannula that has to be cleaned. There is a scrubby for that in your trachcare kit. So, before I start doing all that, I've got the container, I've got everything opened up. I've got just my regular gloves on because I've just done giving them a treatment. You can open up your trachcare kit. This is what I do. Take off the split 4x4, which we generally use under here so that it doesn't cause irritation. Now, some of these patients come with these flanged sutured down. You might not be able to use a split 4x4 under here. But if you do have one, you can still take that off with just your regular gloves. You can take this out with your regular gloves, and there should be a container in your sterile kit for you just to drop that in. Now in our kits, is in one container is empty, one has my sterile gloves in it. So I've opened that kit up, and I'm sorry I couldn't get you a kit, but it's a charge to the patient every time, you know, so I can't just bring, so I'm trying to describe it to you. So I've taken this out, dropped it in one side of the container, and again I have my liquids open, and I've either poured my peroxide in that one side, or I'll pour it in the one side of the container. And then that next one, I will take out my sterile gloves and put my sterile gloves on and start doing my my trachcare. Again, I don't know what supplies you're going to have in this trachcare kit. That list is just what I like to use, which I have to get the extra Q-tips out of our stock bin. In the trachcare kits that we have, they have the gauze that's not really tightly woven. It's really stringy. You don't want to use that split 4x4 that's in that container if it isn't tightly woven to put underneath this trach. So I will again grab it out of stock. Now, once I've done everything that I want to do with the Q-tips and dried him off, you can scrub your inner cannula, and you need to also rinse it in the normal saline. And I pour the normal saline through the inner cannula to make sure that peroxide is rinsed from the inside. All you have to do is tap it off and then put it back in. If I find that I cannot get everything out of the inner cannula, our trachcare kit has the metal pipe cleaners also that I will take and try and get everything out of that with. Also, your extra gauze in there, you can wipe the face plate off. And sometimes up here in the crevices, I will take the pipe cleaners, get them saturated with normal saline. If it's soiled, it also cleans up here, the pipe cleaners. So basically, it's going to be what supplies you'll have access to, and what supplies you feel comfortable with in cleaning him, or the trach, around the trach. So, any questions about any
How
of
long
that?
does that process take?
It depends.
Okay.
No, maybe 10, 15 minutes. Because generally I've already suctioned them, and you shouldn't need suctioning again. But then you may have to stop and start over if you have to suction again.
What trachcare kits do you use? What's the name of them? Do you remember?
I think right now we have the Med Choice or something right now. But we
Medline?
Med what?
Medline?
Maybe it's
Makes them, but
Medline.
it's efficiency.
Yeah, I mean, but it had two. One of them was smaller than the other, and it had a takeout container and just one container.
Okay.
So,
It's better to have more of the.
I think so, because I like to clean with peroxide.
Okay.
But like I said, they said, our infection control says we no longer need it, but therapists and nurses want to use a peroxide still, so, for cleaning. But just always remember that if you apply a peroxide, you have to wipe it off and dry it. Now, the split 4x4s, like I said, should go, and they just fit up underneath the flanges. Now, I can't put one up there if I see them come in with it completely sutured, and you don't really want to mess with that. Their trach tie here, our policy has changed. It used to be that we've changed it twice a day. It is now just soiled, if soiled, or when needed. But in the event that I do have to change this, I do not, because I'm by myself, I do not release it. I will take the trach tie and just put it back around him, slide the Velcro down. I don't know if you can see that. But I will slide these down. One's on it kind of tight. And just put another one through. And what's nice about these phalanges are they're plastic, you can kind of bend it up so you can get it underneath there. But I will not release it unless I have a second person in there to help me. And I do have to go around the bed, back and forth, because I can't reach usually. So once I've got the second one on, then I will release. I do not take it off. And I especially, at the facility I work at, we have some patients that are confused and combative, and I will not do it. I will refuse to do it. It's that way, because I don't want to lose her airway. It's not that important. Their airway is more important than changing that. Or if I have somebody that can help me. Any questions about that?
I have a question not on that though.
Uh-huh.
All of your patients that are trach you use a mask with?
A trach mask?
Uh-huh.
Yes.
I'm used to using like a T-bar so you can have a ballard in there because
We
you suction it
can't-
so often.
We
You
can't
do that?
use, we have to sterile suction also.
Yeah, that's.
In the facility that I work at though, these people are coming in there and they are working with therapy 5 hours a day. They are there for therapy. So we have to make these patients able to get up in a wheelchair, go to a basement, a big therapy room. So like I said, as far as transportation, they may be transported to the basement where their gym is on a Veni mask, and we'll have an aerosol set up down there for them.
And if they need to be suctioned down there though?
They gotta bring them back up.
Yeah. I work in another facility and it is also a rehab that has like 40 vent patients and trach patients. And so it just seems so, we all use T-bars with the ballards in because the same thing, they're transported, they need suctioning and you can suck them.
Yeah, no. That's why. I always, like I said, with the backup trach too, you always want to keep your syringe in case you need to ventilate. You have a cuffed patient. You always want to inflate. So in case of an emergency. Most of our patients, by the time they get to me, have their cuff deflated. They are already working with speech therapy, who is the ones that do prescribe and work with the speaking valve with the patients.
Lori,
Yes.
if they come in and have their cuff deflated, how do you know how much air to put into the cuff if to reinflate that cuff if you need to?
If you need to reinflate the cuff, it's generally, you're going to put the air in until you can't put any tension on the cuff. And another thing, you're going to use your stethoscope and make sure you don't hear any air movement.
You're not
Other
hearing
than-
any, when you say you're not hearing any air movement, where is it that you're
Around,
listening?
in the neck, on the neck,
Around the area?
around the neck, yeah. Yeah. And I haven't worked in acute care in 10 years, so, I mean, but you know, when we had vented patients, you know, that's what, yeah, so, yeah. But generally, everybody's cuff is deflated. And like, for instance, this fella here, he's got a size 8 in. If I'm working to cap him or plug his trach, because again, it's our goal there is to decannulate these patients. If I hear, once I've capped him, stridor noises, because I do listen to the necks, I'm going to say, now, there's not enough space there. One of the things that could be occluding it is the cuff. If you notice, there's a lot there. And of course, you know, this can get occluded too with crud. But generally it's the cuff, even though it's deflated, there's still a big amount there, especially in these bavonas. That's deflated. And that's when the doctor will say, we're going to downsize. And we're going to downsize to, he's got an 8 in, we'll go to a 6, uncuffed. Now generally our doctors do not use the fenestrated tubes at our facility. Our stock is a CFS, uncuffed, unfenestrated. Reason being, you can get growth in these fenestrations if these had these trachs in there for a while. And then, if we can't decannulate them, they've got to go back to the main hospital, have an ENT take it out. Now we have had, generally we have one doctor that usually follows, or 2 doctors that follow these trachs. On occasion, we've had ENTs that they're going to downsize the trach, but they want a specific trach. And in that aspect, you know, we'll have to call and get that ordered for them. There's also doctors, too, that have a specific way of wanting their trach care done. I did have a doctor that wanted the vinegar and water. So, but we have, like, you know, our trach care policy, which I gave you a copy of, our trach care checkup. Do you have any questions about anything? Any questions about identifying the different trachs?
Why do they put fenestrated ones in?
It's just a doctor preference that I know of. Like our pulmonologist, don't know why they do it, you know. We've had some pulmonologists following some trachs. Why would they do that? They get the growth in there, it's harder to get out. And he was there to change, you know, downsize our trach, so.
Wasn't the original purpose so someone could speak?
With the trach?
The fenestrated.
With the fenestrated.
That was
Well-
originally why they developed them, but
Yes, but
Right,
They've
now
got
they have
that.
Now
the
they have
speak valve,
passing nerve,
but that's
right.
why they were first created.
They were first
And
created,
that
so you can
Bavona, I mean,
get airflow.
there's that Bavona in your sheet that I gave you. You know, it doesn't even come with a cap or anything to wean these patients. It's just all one piece. And all cuffed. We do have what we call a universal cap that we can, and I'm not saying that we haven't decannulated a Bavona, but we're able to cap one of those with our universal cap. Any question? Yeah?
One other question, Lorraine. When we get these patients, they'll come with a trach in, okay? And if they don't come with a trach that should be at the bedside, because they should all have a backup trach at the
Right.
bedside, and we should always have a method to help with their airway. If they don't come with that, how will we know what size trach to put at the bedside? Because as you mentioned, you always want it to be less than the size of the trach that they have in. So if they
Right.
pop it out, how do I know what size to put in?
You're going to always, your markings, and your screener should tell you exactly what trach they have. Now, we do want to have the equivalent trach. But because we deal with these trachs at our facility, we have them stocked. So if I don't have the exact trach, that's when I'm going to look for the equivalent of this as a backup. Not to say that first trach I was talking to you about that I had no clue what it was. That specific trach, I did have to call and get a replacement from our central supply because it was a disposable inner cannula. They look like an accordion, and it's twist on like the permanent, but it wasn't. So that's what I said, and if I don't recognize that, I will look it up and find out the parts number. You can do that all online. But I think I've seen that trach twice in 8 years, so.
Do you deal with Cortex at all?
Yes, that's a Bavona. It says, this one's an air cuff air,
But
and
I
then
think
there's
there's
that
just regular
Bavona Cortex too.
But the most common Cortex is not the Bavona.
Is not that one? Then I don't know. I guess I haven't seen that. But the Bavona is listed, there is a Cortex on it.
But mostly Shively is what?
Shively.
you carry. Yeah, the Shively.
Yeah, and a lot of the surgical patients come with the Bavona too.
Probably
Like
just it's a
trauma
fresh
patients.
surgical.
Yeah, traumas. I see them, so.
No, I've never seen the Bavona, but I don't.
Yeah, so these are the two most common that are coming in.
But the regular Cortex is just, the inner cannula just clips in. I mean, it doesn't have the clip on the side, you just push it in and pull it out. It's very easy to work with. Smooth, it's nice. And what I like about using the Cortex, here it wouldn't matter, but say if you're having problems with the inner cannula, you take it out, you can still attach a ventilator. You know, the attachment.
Oh, the outer diameter is
is
not
on the-
changed.
yeah.
Oh, okay, I guess, see, that would be one I'd be looking up. So, but no, these are the common ones that we,
So if we just had the Shively's here,
mhm.
you know, as far as what our replacement at the bedside, et cetera, we would, as you had said, if it's not the same that the patient came with, we would look to use one that's just slightly smaller in size.
Right, never want to go,
put-
yeah.
You don't, yeah, you never want to go up in size.
And you'll look at this one. This one's just huge. This is a 10, and this one is,
6.
this one's an 8. And look at the diameters of those, outer diameters. So you always want to make sure. And again, it's going to be on your hospital policy if that's acceptable. And we stock Shiley's in only one particular one, the CFS is the uncuffed, unfenestrated at our facility in size 4, 6, and 8. Again, because we're trying to decannulate and downsize.
If someone does decannulate, are you allowed to reinsert? Or do you
We
have to
cannot
get
reinsert.
Yeah.
Doctors at our facility, doctors have to do it. Now, if it does partially come out, I have no problem, trying to get it back in there.
Mhm.
But we've had them take them right underneath and phew,
Yeah.
right across the room.
Yeah.
So, and another thing too, when you're doing your trach care, maybe changing your trach band, you should only have like a finger that you can fit in that band.
Right.
So that it doesn't come up, get coughed out, or they don't put their finger up there and flip it out.
Or it doesn't just, I've noticed that if it's too loose, it actually rubs and they can.
Right, that's
actually
a
cause
reason,
sores.
that's another reason for the 4x4 gauze, if you can fit that underneath there. And sometimes I'll use, in our split 4x4, it'll come with 2 gauze. If I feel like 2 is too bulky for them, because I want to provide enough comfort so there isn't friction rub there, I'll just stick 1 in. And nursing likes to, we only have respiratory therapists from 6 to 6, and nursing does a trach care at night. Some nurses like to put their split 4x4 with the split going down. I like to put it up. It's your preference. Same thing with the trach care, how you want to clean. Some nurses like to use the 4 corners of the gauze. I like to use the cotton tip applicators. It's all up to what you want to use.
How often are you doing your trach care?
Twice a day, and if needed, or PRN. The gauze, same things. If you have a lot of mucus or some seepage around the trach,
Yeah.
you're going to change that gauze every time you go in there.
Mhm.
So, I mean, I'm big on stocking in case of emergency in that patient's room. I want to have ample amount of suction catheters, split 4x4s, if I need extra trach care kit. But I want to know it's there when I need it, when I go in there. I don't want to have to walk way down the hallway to get it. So I like to keep everything stocked. Any questions?
Thanks, Lori.
Good.
We appreciate it. If you'd like to